We move to the last presentation because Jean-Louis is not here. So from University of Nigeria, the title of the oral presentation is Hepatitis Delta Virus Cause Super Infection Surveillance Among Clinicians, an often neglected practice in Nigeria. You have the, is it here? So we have two missing, I think, two missing presentations. Is the presenter is here?
No, she's remote. She's remote, but she's there.
Ah, okay.
I'm here to present on Delta virus superinfection surveillance practice among clinicians in Nigeria, an often neglected practice. These are my team members and their affiliations. I have nothing to disclose. And then according to Globacom report of 2020, liver cancer, of which 80% is hepatocellular carcinoma, was the third major cause of cancer-related death, with substantial burden in sub-Saharan Africa. Now, I will take us to this report by Yang et al. That showed that hepatocellular carcinoma occurred with an earlier age onset in individuals with HPV-induced HCC in Africa. Interesting thing about this study, or what I find interesting about this study, is that while they had no data, absolutely no data on HDV status of this group of people with HPV-induced HCC. And so I inferred two things. It's either they had no reliable HDV data that will inform their statistical inference, or they absolutely neglected the important contribution of HDV to hepatocellular carcinoma. Now, we know that HDV is a defective virus that will require hepatitis B for infection, often causing the most severe forms of viral hepatitis and quicker progression to cirrhosis. In Nigeria, you will notice that proportion of individuals with HCC also present with serostatus that will suggest inhibited HBV DNA replication. Notably, HDV would worsen HBV infection while inhibiting HBV DNA replication. Our country, Nigeria, is a hyper-endemic region for hepatitis B virus. And so it shows that there might be an unknown or hidden HDV burden in our population. However, we don't have an optimal HDV surveillance because of non-existent treat testing or management protocol in clinical setting in Nigeria. So against this background, we decided to conduct a survey among Nigerian clinicians to understand and evaluate their HDV awareness and surveillance practice. And so we used a 20-item questionnaire, which we prepared and distributed and they're using social media platform during the month of June of 2020. And so when we got responses, we analyzed the data. This was the data representing the demographics of individuals that responded to our questionnaire. There were about 198 respondents, of which 26 were males, females, and 74% were males. Majority of them practice at tertiary healthcare institutions. Then it was important for us to understand this background because in Nigeria, tertiary healthcare centers are places where one will expect to have kind of access to specialized care, specialized management, and specialized diagnostic care in Nigeria. So we expected that if there will be any surveillance practice for HDV, we will have it in these tertiary healthcare institutions. Amongst the category of our respondents, 68% of them were actually specialists, with 61% having 61% being gastroenterologists or infectious disease experts with some form of training on viral hepatitis management. And so when we ask the question about what they know about HDV infection, we realize that majority of them, about 90% of them, we are actually aware of HDV infection and the fact that you needed to have HBV infection before you could be infected by HDV. Now, when we requested if they screen for HDV amongst individuals with HBV or even amongst HBV-induced HCC patients, about 95% of these individuals who were aware of HDV infection said that they don't screen for HDV, while 11 of them, representing 6% of the population, said yes, they screen sometimes. And when we further inquired, we realized that they only screened for research purposes and not for clinical management of patients. And now we wanted to find out what could be the possible factors that might be the reason for them not screening. Majority of them said that about 56% of them said there were no available screening tests available in their centers, while 35% said that they are not aware of any screening modalities for HDV. And so when we inquired really to know if they really know what to do, assuming they have testing facilities in their centers, 35% said they don't know how HDV is being screened for, while 31% said they used HDV antibody for screening for antibody. And now when we inquired about the management protocol with HDV, of course, not surprisingly, because majority of them do not screen for HDV, majority of them say that they have never treated anyone with HDV. Of this number, majority of them do not even know the current modalities of treatment in case if they have patients with HDV. The few of them who treat for HDV said they use nucleotide analog, PEG interferon, and supportive care. And so the insight we could draw from this, our survey, is that while majority of Nigerian clinicians have medical knowledge of HDV and its screening modality, still they don't screen for HDV, majorly because of unavailable HDV screening services in various hospitals in Nigeria, as well as most of them do not know how HDV is being screened. This will buttress the review that suggested suboptimal surveillance and lack of standardized laboratory method for HDV detection as a key challenge, one of the key challenges that you will see when you try to obtain representative data to fully understand HDV infection. Of course, while in Nigeria we have routine HBV checks in the country, the same is not the same for HDV. And Nigeria may not be alone in this total neglect of HDV surveillance. Because when you look at some other studies that try to show HDV prevalence globally or in sub-Saharan Africa, you will see many nations with absolutely no data on national HDV prevalence. And so there is need to address this lack of public health interest to HDV so that we can push interest towards practices that will help generate the much needed epidemiological data that will help inform evidence-based policies for HDV in sub-Saharan Africa and in the world. Now, we also realize that most of our respondents do not have any idea of the treatment modalities for patients with HPV, and so we call that there need to be continual awareness, sensitization, and retraining of clinicians with respect to HDV management. In summary, our survey showed high level of HDV awareness amongst our respondents, but non-existent clinical surveillance practice due to lack of testing facilities in most healthcare centers. And now, in conclusion, is Delta viral hepatitis really a global problem? Now, although we know that HBV prevention targeted at elimination might be able to put an end to HDV in the long run, but there are questions that still demand answers. What will happen to over 20 million individuals that are already infected with HDV? What happens then to the missing millions that we are yet to identify because of suboptimal HDV surveillance in many nations? What will happen to the 240 million HBV surface antigen positive individuals globally who are always at risk of HDV infection? The time to act is now, I think. And to this, I come to the end of my presentation. These are my references. And I thank you for your attention, and I await any comments on my email questions. I'll be very happy to attend to them. Thank you very much.